Manzar Bhai is there as well.
What
So
what we can do is maybe the panelists can turn off their videos, so we can just have the speakers to start with, and I can introduce the panelists afterwards.
I think we are ready to start, please.
Okay, so please confirm me if
Okay,
we should be
are we
live.
live now, Umair?
Yeah, we are live
All
on
right.
Facebook.
Bismillahirrahmanirrahim. May I welcome all of you to the 7th webinar organized by the British Pakistani Ophthalmic Society. Today, we are very fortunate to have Ms. Stephanie West from Southampton General Hospital, Mr. Umair Kidwai, and Mr. Safdar Raja, who are going to talk about the experience with regards to CESR, how one can use this route to get on the specialist register. Ms. West is going to talk to us about the excellent training scheme for CESR they have established in Southampton General Hospital. Mr. Kidwai is going to share his own experience of how to fill an application and be successful in this process. And Mr. Raja will share his experience as an assessor, as a CESR assessor, that what he looks in an application and what is you can say, a successful application. How do you get a successful application through the system? So may I first request Ms. Stephanie West to share her experience of Southampton with us. Ms. Stephanie West is a consultant ophthalmologist with special interest in pediatrics. And thank you very much for finding time to take part in our webinar. So over to you, Ms. West.
No problem. Thank you very much to the organisers for inviting me to come and talk to you today. So I am going to tell you a little bit about the Southampton programme that I set up, a bit about the background on why I set it up and how it's worked and what has happened so far with it. So I joined Southampton General Hospital in 2013 as a consultant. And at the time, we were serving a population of about 1.9 million and about 3.7 million when it came to our specialist services, because we're a teaching university hospital. We had the equivalent of 20 full-time consultants and 8 what are called ST trainees. So these are our sort of deanery trainees in our national training programme. And we were doing about 120,000 patient episodes per year. At the time, we had a big sort of rota of all our doctors that was run by our operations manager. And we had these posts, which were sort of from the previous training scheme of having SHOs and registrars, called LAT and LAS posts. And these were posts where there would be gaps in the training rota originally, where we would appoint doctors for a temporary period of time, either for training or for service. At the time, there was a very high staff turnover, particularly in these posts, and we were therefore reliant on a lot of locums. We had a lot of staff sickness and a lot of low morale. So it was quite depressing, really. I got involved more by chance than anything, because I got sort of roped in to being part of the interview panel for 2 of these LAS replacement posts. And, you know, we put out an advert and we only got 5 applicants. We shortlisted 3, only 2 turned up, and actually none of them were what we felt was appointable. We ran a big, service. These people would have to be an eye casualty. They'd have to have enough experience to be safe. And sadly, that wasn't the case. So what was hard was how had we arrived really at this point? Because Southampton's actually a great place. You know, it's a big teaching unit in an affluent part of the country where you've got an airport, you've got the sea, beaches, wonderful place to live. And not only that, but the eye unit itself has all the tertiary, well, most of the tertiary level subspecialties, not the sort of the quaternary ones necessarily, but really good peripheral hospitals nearby. it's not a standalone eye unit, it's part of a big hospital, so it's got links to the main hospital, and really good academic department with Professor Lotery and linked to Wellcome Trust. So there's lots and lots of opportunity. So it was kind of odd that we couldn't attract good doctors. And essentially this problem had happened really nationally because of the change in national recruitment. So what had happened prior, well, what was in place prior to this is that you would often get a standalone SHO job, then an SHO rotation, then you might do a LAT or a LAS post, then you'd become a registrar. And essentially, if at any of those stages you felt that going up the training ladder wasn't necessary for you and you maybe wanted to be a staff grade, or if you wanted to create your own training scheme by rotating in these different jobs in different units, you could. But this was all replaced by a sort of a national program where literally someone with no ophthalmology experience would start at ST1, not move place, and finish at ST7. And they only limited the number of places to about 80 per year. So there was a lot less movement of trainees and a lot less kind of spare trainees. This was compounded by the changes of immigration, which is sort of quite ironic now because we unfortunately lost a lot of non-EU doctors, and now we're probably going to be losing EU doctors as well. So this was causing a big problem for us and resulted in many issues. Obviously, our population is increasing, so we needed more doctors at all levels, and we needed lack of staff also impacts on our trainees and our ability to deliver a high quality service and an ability to deliver on call. We're also under the European Working Time Directive, so the amount that doctors could work was becoming more restricted, so you needed more doctors to provide a good service. So essentially I was like, well, we need a solution to this, and the solution is to provide more keen ophthalmologists with a training program, because that is what they want. And actually, when you have a training program, you attract good quality doctors who want to stay long term, and the better trained your doctors are, the better the quality of your service. One alternative was whether national recruitment would increase their places, but in fact, that wasn't ever going to happen and still isn't. I think that has been explored by the college, but isn't going to do that. So I created this alternative training program. It did involve redesigning our rota. So classically in the UK, we work Monday to Friday, and we have 2 sessions a day, a morning and an afternoon session. And what they sort of term service sessions are literally, you know, working in eye casualty or doing straightforward clinics, literally seeing patient after patient after patient to keep the workload going. So traditional service post would have 8 of these service sessions a week, and then a teaching session and an admin session, whereas a CESR training post was going to be exactly the same as one of our deanery trainees. So they were going to have admin research, also teaching. They were going to have 2 theatres, one of which would be a casualty. This is per week, only 1 casualty session, and then a combination of things like subspecialty clinics, laser and injections. So this results in a loss of what we call service sessions, which isn't very popular with management, unfortunately, because they see that as a loss of work and costing more money. We also created some rules, which I've sort of alluded to already. One of the things that enabled us to do this actually was we expanded our NHS cataract lists by actually borrowing a theatre from Optegra, one of the private hospitals, because Southampton was very limited on theatre capacity. We also made sure we only have 1 trainee per list, so we don't have a deanery and a CESR trainee on the same list, to make sure they're getting maximum training. We had to get the whole sort of management consultant team on board, and in fact within our unit that wasn't hard, but further up the sort of food chain of management, that was a bit harder to convince them of the value of losing these service posts. And we used our funding from our locums, we sort of identified that, and we got the posts approved as fellow posts, and I became the lead to kind of ensure that we delivered it. So I created a portfolio pack, and I also allocated educational supervisors. So everyone in the UK who's a deanery trainee has a consultant who is an educational supervisor for them, who basically makes sure that they're getting the training that they should and helping them navigate that route and reach the standards that they should. The sort of slight difference is that when you're a deanery trainee, you undergo an annual review called your ARCP, done by the deanery, and that's just sort of lets you progress. Whereas when you're a CESR trainee, I was still doing an annual review for you, but you also had to have a trust appraisal to make sure that you met revalidation guidance, and that is still the case for the GMC. So they definitely have to do extra paperwork. So this was the advert that went out. As part of the portfolio, as part of the sort of what I expected people to do and achieve, I laid out all in this document, and I got them all registered with the e-portfolio in the college. I'm sure some of the future speakers are going to say about the arduous paperwork that has to be submitted to get your successful CESR application through. So they still have to print it off, but at least being as part of the e-portfolio, it enabled them to get them signed off electronically and to see where they were as well. So what were the benefits for us for running a local training program over a deanery one? Well, we had control over who we selected to do the job. We also gave our trainees fixed term contracts. So you would get a year's contract to start with, and then obviously based on your annual review, you would then get the next year. And that's really because the whole point of this is to get people well trained who can become consultants. What was very good about it is that classically in August in the UK, all doctors switched roles, and that can cause absolute havoc in a unit because suddenly you can lose all your trainees who are manning on call and suddenly get a whole load of new trainees who aren't so familiar with your systems and setups. But actually having the CESR workforce meant that that was stable and made August handover much safer. And actually the trainees that we got, we found are extremely motivated. And they work very hard and they do lots of good things within the unit, including projects, and work very well as sort of kind of team members. The worry, and this actually some of the worry came from our deanery, was what was the impact going to be on our deanery trainees? Are we taking training away from them? Our management was like, well, this is going to cost us money. Because look, we're losing service because you're spending time training them. And obviously there's extra work running this program. And we need a cultural change within our unit, because I wanted very much these trainees to be thought of as no differently from our deanery trainees. And actually that within our unit itself, that was really easy. We didn't have any problems with that at all. Slight concern as well as they're not under national regulation like a deanery program, and would we pick trainees who would actually succeed? So back in 2014, we shortlisted, we had amazingly 24 applicants for 4 posts. We shortlisted 8 and appointed 4, and all of these candidates did have UK experience at the time. They had had good clinical experience, but not surprisingly, their surgical experience had been quite limited. And this was kind of consistent. If you weren't in a training program in the UK, you pretty much weren't getting much surgery, sadly. This is just to give you an idea of the kind of firms that they did. So each firm is 6 months. 3 and 4 started a bit later on in the middle of the 6 months. They kept going for the future 6 months in what they were in. Sometimes there would be a deanery trainee who would be part-time, and that would enable there to be half a week's worth of rota in one of the more competitive specialties. So we would take advantage of that. So that's why there's a sort of slightly unusual combination there. I was the CESR lead and I worked very closely with the college tutor. We then decided to allocate what we call ST levels. So similar to the deanery trainees, we would indicate at what level our CESR trainee was. This is so that they knew where they were roughly in their training, but also things like, the most 6 senior doctors are on the second on call and the other most junior ones are on the bottom. So it made that more straightforward and clearer for everyone. Sorry, excuse me. We got a medical administrator who would make sure that the rota rules were all kind of followed. And I brought in an external education member from the trust. So we have people within our hospital trust who specialise in education. And I brought someone from out of ophthalmology onto the annual panel, really to make sure that we were doing a good job, being fair, consistent, etc. We were having monthly consultant meetings where we discussed all the trainees, and that included the CESR and the deanery ones, as well as now that's been expanded to fellows. Actually, there was a question of whether we should expand the programme further. We've always resisted that, partly because of the lack of theatre that we have, because that is the key thing on being able to offer good surgical experience. We have had since a couple of non-formal trainees who we've helped get positions into ST posts. And in fact, we are finally potentially getting more theatre. So that might be that we expand the programme going forward. This is just a little bit of data really that we collect to look at how the CESR programme affected Southampton. And this was to answer quite a few questions, partly the concerns from the deanery, concerns from management. We compared the year before with the year 2015. Sadly, we've not been able to repeat this because after that, the new junior doctor's contract came in and everything changed for CESR and our deanery trainees. But as you could see, our outpatient episodes, so that's clinic appointments, increased. So that despite losing service sessions, there wasn't a decrease there. The number of procedures, things like intravitreal injections and lasers, that also increased. The same with the number of elective and emergency procedures in theatre. And service quality. So a measurement of service quality can be your eye casualty follow-up rate. So we do bring patients back to eye casualty for checkups. And the more senior your doctors, the more confident they are and the less likely they are to bring back follow-up patients. And as you could see, percentage-wise, there was a small reduction. And although it's only small, this was actually statistically significant. So this is one of the good arguments to have better trained doctors as you are treating your patients better, providing them better service. This is just a reflection on the referral to treatment target in the UK. It's obviously all gone a bit beside the, COVID has now knocked this all sideways, but essentially you had to get your patients treated within 18 weeks of referral, and that obviously all improved. This is what how our medical staffing changed during that time. So we went from 21 full-time consultants to 20. These were our deanery trainees. So we actually went down in terms of deanery trainees. We went down in terms of locum, but here we gained our 4 CESR trainees. And this is actually the impact on our staffing bill. So that loss of locums and changing to those deanery trainees reduced our locum bill by 420,000 a year. So yeah, there was definitely no argument about cost or service there. Impact on training. So again, the worry expressed, and I have to say the worry was expressed by the deanery, it was never expressed by the other trainees. So this was the average number of cataracts done by a trainee in 6 months. So 2014, that was 41. In 2015, it actually went up to 52. And that included us for the first time having a very junior person who'd never done any ophthalmology before. So certainly numbers were going up rather than down. Sick leave was a good measure of morale. And again, that massively improved because what was happening before, so one of your colleagues would go off sick, your trainees would have to cover it, so they would lose theatre sessions, etc. And everyone was getting very demoralised. And in fact, in this sick leave in 2015 was a trainee who had a shoulder injury, unfortunately for them, and was off for 6 weeks. So see, the impact was actually even bigger. So what has happened in our programme? So these are our original 4 trainees back in 2014. And Ramez is our first trainee who submitted his application in 2019, so 5 years from the beginning, and successfully got his CCT. 2 of our trainees, 2 years on, got places on the deanery run through at ST3. And for us, that's a fantastic success. We were choosing the right people. We would always encourage our CESR trainees to do that if they can, because it is more straightforward from a paperwork perspective for them, as I'm sure you're going to hear. One of them, in fact, changed later even to an academic post and has done extremely well. Our fourth trainee actually had an opportunity back in her home country to complete training there, so she decided for personal reasons to take that up. Our fifth trainee, obviously, in 2016, we advertised 2 posts and got 36 applicants. And one of those then last year got an ST3 post, so we replaced them last year. Trainee number 6 is still with us, and trainee number 7 is still with us. So these 2 posts got replaced in 2020. You can see in 2017, we got over 40 applicants to 1 post, and then over 70 in 2020. So word has got out about the programme. So Ramez has kindly said I could share what he achieved during his time with us to give you an idea. So he was with us 6 years as a CESR trainee. He covered most of the subspecialties twice. He did over 600 cataract operations. As well as doing the registrar post in cornea, he was also the ASTO in cornea. He gained his FRC Opt, which we actually insist all our CESR trainees do that. It makes it a lot easier from submitting for your application with the GMC. He did an audit per year. He did service improvement projects. He got 4 publications, 3 book chapters, and also posters at ARVOs and ESCRS. And the delay in sort of approval was really down to the college and GMC, but he obviously submitted it all within 5 years, as your paperwork needs to be, got approval last year. He's since done a post-CCT fellowship. He's actually doing a locum in Southampton at the moment and is off to Toronto to do Peds Cornea. He also, I think, is publishing a guide on CESR step-by-step to help colleagues as well. Other things that have impacted on our programme is the new junior doctor's contract. We essentially do the same for our CESR trainees as our deanery trainees. So the rota change is exactly the same. I became clinical lead in Southampton a little while ago, briefly, and we had a new CESR programme lead, Ms. Doreen Khan-Lim, who's done a fantastic job. She's basically aligned the ARCP panel even further with the deanery process, so it's pretty much identical paperwork, and she consolidated the submission process, and obviously was in charge when Ramez got his CCT. And Southampton have been so keen on this programme, they've introduced it in other subspecialties. So, gosh, I've already been talking 20 minutes, but what is most exciting is that last year, the Royal College launched the ophthalmology local training programme based essentially on the Southampton as a case study. And they did this because it's quite clear that in 2018 census, we were short of 170 consultant posts, and they were expecting us to be short by an extra 230 by 2020. We were struggling to appoint staff grades and associate specialists. So they have done a roadmap on how other units can essentially do the same successful programme as us. And I think this is brilliant, because the more good quality doctors that we can get, well trained, the better it is for everyone. So in summary, I think we have a great need for this. Good training improves everything for everyone. We need to increase our consultant pool, but also, even our associate specialist pool. This is a good way to get trained as well. And it is actually, cost effective and doesn't impact on your trainees. So yes, any questions?
Thank you very much, Stephanie, for a great talk, and congratulations for getting it through the management and having a very successful CESR training program at your place. I think you're the first department which has it in UK. Can I ask you, basically, what these CESR posts, were they additional posts to your original workforce?
They were sort of, because we had to sort of sort of mess around with our funding a bit. They were a combination of those locum appointments for service, so those last posts that we had, and a couple of fellow posts. We sort of blurred the funding edges because I think like we had a lot of support from management within the unit, but at that time, and even still about 3 or 4 years afterwards, we met resistance further up in the hospital about trying to justify why you're spending money but on paper cutting service. So we sort of just repatriated those locum posts. And in fact, on the 4 people that were appointed, I'm trying to remember back now, one of those was one of the people that we already had in a last post at the time. So it was sort of repurposing funding within our unit at the time.
Stephanie, there's a question a colleague has asked about when are these posts advertised? I presume they advertise when somebody leaves you.
They are, yes. So at the minute we don't expand. We literally advertise as a vacancy comes up. So we had 2 posts advertised last year, and we advertise the same as everyone else does on NHS jobs. We don't nowhere else. So you need to keep a lookout for them. I mean, we are expanding our sort of theatre capacity at the minute and our outpatient space. So there may be future opportunity for us to increase our CESR training. I mean, once obviously the trust realised it was effective, then obviously they went the other way and were like, oh, you need to get more of these doctors. But we had to be quite protective because the whole point is you need good quality training, and that includes good quality surgical training. So we need to have the capacity to do that.
Thank you very much for the excellent talk, and I hope you can join us for the panel discussion because there are still a lot of questions coming up. So hopefully we can join us for the discussion.
Thank you for inviting me again.
Yeah, thank you. May I suggest that if anyone wants to put any questions, can you put it in the question answer section, because we will take all the questions at the end. So moving on, may I welcome Umair Kidwai, who is a glaucoma fellow at the moment in Queen Victoria Hospital, and he has very kindly agreed to share his experience of a successful CESR application in ophthalmology. So over to you, Umair.
Thank you so much. Many thanks for this forum, BPOS, Mr. Ejaz, Mr. Raja, for the opportunity. Okay, so I know because we've got a variation of attendees here. Some of them are from UK, some are from outside. So I would like to go through quickly the pathways that we have for someone who comes here and work in UK. So being a Pakistani firm, so I've just written Pakistan, but if you're working outside UK, so many of us have been working as a consultant in their own native countries. But when you move to UK, you get this, you basically need a GMC registration, and that's a general license that you get usually. And ideally it's PLAB with English criteria, and normally there's a growing trend for MRCS and FRCS, and usually we do that, and after completing the English competency, we get the license as a GMC, and we come and work on that license. So the type of post that we can get in that license is basically a staff grade post, and classically it is called as a SAS post, which means there's either a staff grade or associate specialist post, which were stopped at some point and now started to re-advertised. Or you can get a clinical fellow post or subspecialty fellow post. All these are legally allowed as a general license. You can work on all these posts, and obviously as a trainee as well. There is also a possibility for anyone on a general license to work as a locum consultant. We'll go to that in a bit. So if you've got a general license, how can you progress? Let me just hide this. So there are 2 pathways to progress, in my opinion. There is one, obviously, another pathway of changing or looking for alternative areas such as teaching or research. But in order to progress clinically, you should get a specialist registration, okay? The other pathway is to get a locum post. You can still get a locum post on general license, but the issues are, we have to understand that, as Stephanie already highlighted the fact that in UK job market, we always get these ups and downs in terms of the availability of the doctors. In some subspecialties, we are really lacking any consultant, and that's where the trusts are willing to hire a general license holder as a locum consultant. But it is possible that after a few years, we might go in this trend up, and the trust might not want to hire these doctors until they achieve the specialist registration. And also, there are some legal restrictions as well, that a trust can't keep a locum consultant for longer than a few years. Although, considering there's a growing demand for doctors and ophthalmologists, that's why many trusts are not actually looking into the legality of these things, but it can change quite quickly. And again, the important is that this post is not always available. It's on, not every subspecialty of ophthalmology is in high demand. So it might not be very easy to get a locum consultant post as an oculoplastic surgeon or as a cornea surgeon or a VR surgeon. So how to get the specialist registration? So there are three pathways defined by GMC. Number one is the most recommended pathway is to go through the UK training program. We can enter in two ways into that training program, as either an ST1 or as an ST3 trainee, okay? Usually, because most of us has got experience over a year, so we become ineligible to apply for ST1 post, but we can still apply for ST3 post. Again, as Stephanie said, it is highly recommended that you go for that route, but the issues are that we still have the labor market test. So until you are a British citizen or a EU citizen, which has changed to some level as well, it is difficult to get the ST position. Although you need an extraordinary portfolio, people has got the ST number without being UK nationals, but they have got extraordinary portfolios. And so someone can work on that route to achieve that ST3 post. Before coming to CESR, I will go to this another pathway, which is exceptional criteria for specialist registration. But this is something no one should look at, because this is a really, really exceptional pathway. For someone maybe possibly, just an example, working in Japan and maybe making thousands of retinas with stem cells and with thousands of transplants done, then he is an exceptional person and he might get exceptional pathway approval. Otherwise, I think it's a waste of money to consider this pathway at all. Okay, so unfortunately after this, the only pathway left is CESR. So how to proceed? Honestly, this is the biggest issue. So when I first came to UK in 2014, I knew about this pathway, but I didn't know how to proceed. You will hear about everyone asking you to make a portfolio, but honestly speaking, when I first came to UK, I didn't even know what portfolio is. The biggest question is how to proceed. I think the biggest difficulty is we lack guidance about this process. We can't understand how to proceed with this. So I think the biggest objective of this webinar is to make it more understandable. I think I came up with this map for CESR. It shows you the basic things that you need. So I would say there are 5 mountains that you have to climb in order to apply for the CESR application. Okay, I must say there is one important fact that you should never forget. This is as per GMC criteria. The CESR pathway is exactly the same. It is the same requirements that you have to fulfill, that a trainee has to do it. Okay. Not even a single thing they will ask you, which is not asked by the training program. So the trainee has to go through exactly the same pathway as a CESR person has to go through. The only 2 major differences are, number one is for trainees, they have this process of ARCP, which means that their requirements are checked and signed off every year. So they don't have to pile up all the evidence and submit at the end, okay? which is the biggest issue with CESR. So we have to fill up all the requirements, and then at the end, after 5 years, 6 years, when you complete all these requirements, we have to complete all these requirements, file it up, and submit on the application system. This is the biggest difference. On the other hand, for trainees, that's not the case, because they've got ARCP meetings every year, which is a part of, they submit the evidence online, they've got supervisor meeting, and at the end, they've got ARCP face-to-face meetings, and they can discuss the limitations and the things that they have to cover up in next year, and so on and so forth, which is not the case here. I think the second biggest difference is the lack of push. Most of us we are working as a staff grade subspecialty doctors. Most of us are earning good money as a staff grade. We've got more family-oriented life, and on the other hand, the trainees got this constant push from the ARCP deadlines, from clinical supervisors, training program director, that they had to do these requirements in a year's time, otherwise they will be penalized or other things. So there's a constant push on the training pathway, which we lack in this pathway. So these are the two major differences in the CESR pathway than the training pathway. Otherwise, you have to do exactly each and everything as a trainee has to do, not even a single thing more than they have to do, okay? So I'll go through in each and every element of these. As I said, the simplest way to understand is that you have to complete all these 5 elements: exam, FRC of the exam, complete competency list, complete the number of surgeries, complete the number of clinics that's required. And there are some list of portfolio related things that you have to complete. And after that, you can submit your application. I'll go through each and every one of them quickly. So number one is the exam. So I think this is the biggest of all these things. And as a staff grade, most of us have already done FRCS from different college. This is the biggest issue. So when we complete our FRCS, we think, okay, fine, we've got enough qualification. We don't need any more qualification. But unfortunately, when you go to a different system, they've got different regulation. And unfortunately, we have to follow those regulations. Previously, lots of people have done CESR without FRC Ops, but now college guidelines are very clear, and they have categorically said that they won't accept any other evidence than FRC Opt exam. So this is the biggest hurdle for anyone who wants to pursue the CESR pathway or any other training pathway. They have to do it. Trainee has to do FRC Opt. Similarly, CESR trainee has to do FRC Opt as well. I think the biggest issue is to do the part 1, because we all have done our basic sciences examination 10, 15 years ago, and we don't want to go back to our basic sciences. But unfortunately, this is an effort, but it pays off. I would like to give a few more suggestions here. Number one is, we have this, we all assume that in order to go through the FRC of the exam, we definitely have to do part 1 first, then we become eligible for refraction exam, and so on and so forth. I have suggested it to a few of my colleagues as well, and this college allows us to sit in refraction exam before the part 1 exam. So if any of you are working in pediatric ophthalmology or doing lots of retinoscopies these days, I think it's a good opportunity for you to start this pathway from refraction certificate rather than the part 1. And once you pass this exam, you get the confidence and motivation to go for part 1 preparation, which might take a bit longer than that. Again, a very important element, which Stephanie also highlighted, is that the basic policy is to have a well-trained or better trained doctors available. So we sometimes forget, in order to achieve our goals, that the biggest achievement is to improve ourselves as an ophthalmologist, improve ourselves as a doctor. So I think going through this exam process not only helps you improve your CV, not only helps your application stronger, but it definitely improves you as an ophthalmologist. Okay. So especially I would definitely emphasize that there are lots of components in part 2 oral exam, which improves you in communication, which improves you in ethics. I personally think that my ethics have drastically improved after I sat in the exam. Because of the preparation struggle that you go through. which I don't think so I would ever have gone through without going through this exam process. So this is strongly recommended that if you want to pursue CESR pathway, you have to do it. Unfortunately, there is no other way. Please stop thinking about other ways. You have to do it, okay? Even if you don't want to pursue pathways, if you're working in UK, it's a good opportunity to improve your CV by going through these exams if you're working in UK. I don't want to go through on all the details of the competency list. It's available on college website. You can easily look through it. At the moment, there are 180 competencies, but 15 of them have been removed. So you have to finish off about 165 competencies, okay? But I must say that these competencies keep changing, and before the submission, you have to follow the updated guidelines of the competencies. For example, it is possible that they might improve, they might remove the refraction or let's say IV drugs from the competency after 2 years. So you don't have to do it. It is also possible that they might add another competency, for example, refractive surgery. So you have to do that at that point. A trainee has to do it as well, and you have to do it as well. So the college guidelines keep changing. And if they add another competency, we have to follow that competency. In order to do these competency, if you click on each and every competency, the college also tells you what sort of evidence is accepted. There are some work-based assessments that you have to fill in, like OSATs or DOPS. And sometimes you have to fill in some CBDs as well as part of the competency sign-off. Now, I've just combined the other two blocks of the CESR map, which is the number of surgeries that's required and the number of subspecialty clinics that we have to complete before we submit the application. I think this is again a bigger hurdle after the exam that we all come across. For example, if someone starts working in UK and they don't have a good surgical experience, completing the number of 350 cataract surgeries, all fully done independently, sounds like a big aim, but it is achievable. Similarly, you have to assist in about 6 corneal grafts, 30 glaucoma procedures, 20 VR procedures. You have to perform full squint surgeries, 20 squint surgeries, and so on and so forth. Similarly, temporal artery biopsies as well. There are no numbers identified, but at least have to do 2 temporal artery biopsies because you have to sign off 2 OSATs with that. So at least 2 temporal artery biopsies needs to be done. I must say again, please don't lose your focus on it, because we are doing CESR to achieve something, but also the biggest aim for us should be to become a better ophthalmologist rather than improving your CV and achieving the CESR. Trust me, if you try to become a good ophthalmologist, you will automatically achieve CESR, you will automatically improve your CV. You know, lots of us has been working in subspecialties in our native countries, and that's why we don't want to move on into different subspecialty. This whole training program is designed to make you a very good general ophthalmologist, and this is why you have to do it. And even if you're working as a locum or a substantive consultant post, 70-80% consultant posts do require an on-call commitment. So if you are too subspecialty focused, then if you don't have a good exposure of other subspecialty, you might struggle as a consultant. So I think it's really important that we don't lose focus being a good general ophthalmologist with subspecialty interests as well. There are, you know, these numbers sounds like a big numbers. Please don't get frustrated about it. They go through going through your training, it becomes easier and easier on this way. For example, I'll give you an example of this, like 20 glaucoma procedures are required by the college. It doesn't mean that you have to do 20 trabeculectomies. It might be few trabeculectomies, it might be few LPRs, it might be few SLTs. Even though if you're removing releasable stitch from a trabeculectomy, that is also counted as a glaucoma procedure. You can get that sign off. So it is possible. Squint procedure is something that most of us hate unless and until they are working in pediatric ophthalmology. But this is really useful. Even if your subspecialty interest is in glaucoma or VR, doing these 20 squint surgeries will help you in your subspecialty interest as well. So nothing is wasted. It helps you not just in your CESR application, in your CV, but also becoming a very good, useful ophthalmologist. Now, the final component, not last but not least, is really important as well. So we have to do exam, we have to do the competency sign off, we have to do these, finish off these numbers of clinics, we have to finish off number of clinic procedures as well. But we also at the same time make sure that we keep completing these logs. Okay, being a staff grade means that it's as GMC's requirements that we should have a yearly appraisal. As part of the appraisal, we keep a CPD record, so that's also useful in the application process. Keep your thank you letters, your complaints. It's really important that you keep all the records of your complaints. If you don't have any complaints, you must have or being part of any safeguarding incident that you initiated. So anything is helpful. You need to show that you've been part of the community, you've been part of the management system, so you have been working in this system. So keep log of all these things. Be involved in teaching, keep all your presentations, because that could be a good evidence at the end, at the time of application. Involve in your teaching portfolios, involve in graduate training, as well as postgraduate training. Research is always very handy to improve your CV, but as far as the RCOP guidelines, they don't expect you to publish a paper definitely for a CESR application, but it is essential that you at least have 1 to 2 poster presentations, which is not that difficult task to be asked, to be honest. So it is achievable. So don't get disheartened, don't get frustrated. All this is definitely achievable. Okay. Again, a very, very important component is audit. We have done a separate webinar on audits. The recording is also available on our Facebook page. To be honest, I first time did my audits for when I started progressing for the CESR application. But since then, I have been such a big fan of audits that I don't think so I can get away from audits in future. And whenever I look at any medical practice, I cannot accept the competency on that until I see the audit of that practice. It not only highlights how good you are as a clinician, as a surgeon, but it's kind of a good way to be accountable. And it definitely audit improves. I think you all have seen that national audit report. Since the national audit report for last 2-3 years, there has been a drastic drop in PCR rate. It's all because of audit, because everyone now look into their techniques, they improve their technique this way. Lots of people will say they are best surgeon, they are finest surgeon. Until and unless you do your audit, you can't say that you are a best surgeon or you're a finest surgeon. So I think this is essential. Again, it will not only help you with the CESR application, it will improve you as an ophthalmologist. After you've completed all those 5 elements, you can start submitting the application online. But before you start submitting your application, you need to make a detailed CV, okay? The GMC website is very good in terms of telling you all the details that you have to include in your CV. You have to follow the instructions as per GMC website. Step by step, everything is on it. Just follow all the instructions before you start your application process, okay? And then you can start uploading all the evidence. Previously, it was paper submission of the evidence. For last 5 years, they've transformed into online application process. I think that's much easier, and the verification process is much easier as well compared to what it was previously. But I think you need to be ready before you start your application process. So make sure that you've completed all your big 5 blocks of the CESR map before you go for the application process. And then you can easily do this. Now, in terms of the experience I got, before I give you the key advices, I must say that I finished my CESR in about 5 years. And out of those 5 years, 2 years, I was frustrated, disheartened. I didn't know what to do and how to proceed with. And I think, so it is something that is achievable in much less time than 5 years if you are focused, if you've made up your mind. So I think the most important thing is to make up your mind whether you want to do it or not, okay? It might require a little bit of compromise, but I think it's achievable. If you have made up your mind to go for CESR process, start preparing for the exam. There is no way out, unfortunately. I think it's really important that you try to be good friends with your trainees, because not only they update you about the RCOP guidelines and curriculum, they will also tell you lots of dinner range programs, which might be very helpful in terms of signing off lots of competencies. Okay, so that's really helpful. They also help you in the exam process. I strongly recommend that you get membership with the Royal College of Ophthalmologists. It gives you access to the e-portfolio, where you can keep the log of all your CPDs, which is helpful in your appraisal process. Plus, at the end, you don't need to look for every CPD certificate. Everything will be in your e-portfolio website, and all you need to do is just download from there. Also, it gives you access to sign off all your competencies electronically, so it becomes much easier. Previously, I have come across my colleagues who CESR application was rejected or returned with objection as they can't understand the handwriting. With this e-portfolio system, online competency sign off, it's much easier. So I would strongly recommend. It's going to cost you money, but fine, go for it. It's a good investment. It also gives you access to the iLog book. Whatever procedure you do every week or every day, if not possible, enter it into iLog book. So at the end, you have everything in the place before you start submitting on the online application. Plus, it also tells you exactly where you are short. Okay, you might think that you've done 20 procedures, but that might not be the case until you have everything entered in the iLog book. So if you got that in the logbook, then you can you know exactly where you are in the CESR process. Again, the first question you need to answer is whether you want to go for it or not. Unfortunately, in my opinion, I think there are no other ways unless you get into the training program. As I said, in order to get to the ST3 post, you need a very strong portfolio. It's getting more and more competitive every day. And if you're working on CESR pathway, your portfolio improves day by day. So even if you don't want to pursue CESR pathway, and if you keep on trying on the training post or ST3 pathway, there's always a chance that you get a training post being working as a CESR pathway doctor. Like Stephanie highlighted, two of her of the CESR pathway fellows went on the training program. So it becomes more and more easier for you. Again, the main emphasis is, try to improve yourself as an ophthalmologist. And this is one of the ways of doing it. And this will make you a comprehensive ophthalmologist. And above all, it will give you a respect. And yes, obviously, it can give you a substantive post as well. One of my mentors, Mr. Raja, who's going to speak after me, this is one of the earliest thing he told me, that being a consultant or getting a consultant post is one thing, but being a good consultant is absolutely another thing. And we all want to be a good consultant rather than just a consultant. Okay, so if you fulfill all these requirements honestly, conscientiously, then you will feel like you have improved as an ophthalmologist, and you will definitely become a good consultant that way. And again, the biggest frustration all of us have is the trainees are getting this and trainees are getting that. And Stephanie has designed a very well program, but not every trust has that well set programs for non-trainee doctors. So I think you have to accept the fact that trainees have gone through a different pathway. They are chosen ones in different ways. Don't get frustrated about that. But on the other hand, you're getting lots of other benefits. You're getting better salary, much better salary than the trainees. You can still progress. So, and this is one of the pathways of progressing in this way. I think last but not least, the most important advice I would give is look for a good unit. Okay, this is absolutely essential. If you want to pursue as a CESR in order to gain specialty registration, and if you're not happy in your unit, then look for a better unit. What do I mean by better unit? Look for a unit where they have more experience of CESR pathways. Speak to them, how supportive the consultants have been in that unit. You might come across that many of the CESR candidates are working in that unit as a consultants. So, and those consultants can become your mentor. And I must say that this has been the case with me. So I moved into a unit which was CESR supportive unit. Lots of people have done CESR before me. And one of my mentor was CESR consultant. He was a consultant and become lead consultant in that unit. I must say what you need is a stick on your head. Like trainees need, trainees got a stick on your head in terms of pressure from the deanery on ARCP. We don't have that stick. And the mentors can only put that stick on your head and keep you focused and prevents you from losing the focus. And this was the case with me. And my mentor always had a stick over my head. Sometimes you feel depressed, you could feel frustrated, but keep focused on your objective and this will help you. Look for DGHs, I must say, because again, they have been struggling to hire people as a staff grade. So they will also recognize the fact that, they need to support you in order to keep you in the unit. So they will help you in terms of pursuing your requirements for CESR. Rather than your fancy big city subspecialty center, which you might find it difficult to complete your requirements over there. Many of you might be very keen in your subspecialty interest, and I assume that that's your comfort zone. But in order to do CESR pathway, you have to accept the fact that you have to be good in everything. It is one of the very good indicators that you're progressing as a good ophthalmologist, is that in the beginning, you're not that useful for the unit, but at the time of completion of your CESR application, you can fill up any sick leave member of the staff easily. So if irrespective of the pediatric consultant being off sick or a glaucoma consultant off sick, you can still do their list or their clinics easily because they know that you've worked with them all this time. It makes you feel more and more confident and a very valuable member of the unit. Similarly, you can't run away from the other things that as an ophthalmologist you might come across. For example, if you are a very keen pediatric ophthalmologist, you might be one of the best pediatric ophthalmologists, but in UK, if you're working in UK, you might be asked to do a temporal artery biopsy. So you have to go through these competencies. They are very, very useful competencies. And again, I think don't look for loopholes. Many of us think about getting these competencies signed off from back home and things like that. But I would strongly recommend, you can do that, college accepts that, but I would recommend that if you are working here, get it done, get it properly signed off here, and doing it as a whole, as a new thing, and this will always pay off. Last but not least, this is one of the famous poets. And so this just motivates you to keep working hard. And I would strongly recommend that you please look into the website of this forum. We keep organizing different webinars and we do try to go live on Facebook as well. You're more than welcome to have any questions if you have. Thank you.
Yeah, thanks, Umair, for an excellent talk. I think I hope you have time to stay till the end of the webinar because we'll take all the questions with our panelists as well. I think in the interest of time, we move on to Mr. Raja, who is going to talk about the CESR application from an assessor's point of view. Mr. Raja is a dear friend of mine. In addition to that, he's a consultant ophthalmologist in James Paget Hospital, where he's also the clinical director, as well as he's a senior CESR assessor for the Royal College, and also a regional program training director as well. So over to Raja.
Thank you, Ahmed Bhai. Can you hear me?
Yes, sir. We can hear you and we can see your slides.
Yeah, lovely. Fantastic talks by Steph West and Umair Kidwai. I think it's a hard act to follow. And Umair quoted the great poet philosopher Allama Iqbal as well. So I think it's going to be hard asked. But just over the next 10-15 minutes, I'm just going to share my perspective. The slides are going to move. Yeah. Nothing to disclose from my side really. I'm a voluntary role as a senior Royal College assessor. I'm also the clinical lead and director for James Paget Hospital. This is my 4th year running for that now, and the training program director for medical retina module. Myself, I have been on both sides of the divide. I did CESR successfully. I think it seemed like a lifetime back, but I also have been an assessor as well. And being a clinical lead has really opened up new perspectives for me to understand the process. The first thing, when you're looking for a job in UK, do Google and find out about the place. This is Norfolk on a nice British summer day, lovely beaches around. So if you get a chance to work in Norfolk, it's one of the good areas to come into. I'm not advertising for James Paget right now, but please feel free to contact me if you're interested. For the CESR roadmap, the key points, I think Steph and Umer have alluded to a lot of interesting points in there. The first question is the why question. Why do you want to do it? This is likely to be the most relevant professional and personal decision you're going to make. And as Umer said and Steph said as well, it's going to take at least 5 years. So be very careful about the why. Why do you want to do it? It's going to take a lot of time from your family life. And most of you might be at a younger age group when then the family would be quite young as well. So it's important to keep that in perspective. The second bit, once you're really pretty sure that you want to do it, how you're going to do it. And Umer has given detailed, extensive review of that, so we don't need to talk about that. Logically, the why and the how question, the gap analysis should follow. So where are you right now? What is your starting point and how you're going to get to the end point? And obviously along the progress, you need steady progress along the line, which means that you got a relatively stable job in one place, because it's very difficult to keep jumping jobs and then finding the CESR assessors and completing your portfolios, competencies, and whatever. So now solving the question for the why and the how question regarding and the job analysis, is there a job market? Is there a demand and supply issue within UK? And what can you offer if your entry point is from subcontinent like Pakistan or India, Burma, Sri Lanka, Bangladesh, or elsewhere? Now, the good news is that there are lots of jobs in ophthalmology. This is the census that Steph referred earlier to in her talk as well. There are about, I think, 300 consultant ophthalmologists required at this stage. And this is from 2018. But I think three years fast forward and after COVID, the need is probably greater. And there are lots of reasons why there is increasing demands. People are living longer. We've got chronic conditions in medical retina, in glaucoma. And so we need lots of people that do need to come to a hospital or possibly manage in the community with consultant and specialist oversight. Another thing is from the same Royal College document, it's probably needed about 200 to 210 middle grades. So there's always a need for a middle grade. As a clinical lead, I can certainly vouch for that. An experienced and a motivated, good specialty doctor is probably worth more than a consultant, especially in a lot of DGH hospitals. Some of you might have had a chance to look at this cycle. This is called the Gartner Hype Cycle, where I'll just see whether you can see my mouse over there. So you start with something like a product, like an OCT machine or an idea or a surgical procedure, and you're very enthusiastic about it. There's a peak of inflated expectation. You're really enthusiastic, you run with it, but then comes the trough of disillusionment, what Umer was referring to. You will have in those 5 years, you will have those periods where they'll go up and down for you. And then slowly you go towards a slope of enlightenment where you start to recognize, well, this is your thing and you want to go through that. And this is where you need mentor. You need somebody who can take you through that. You then enter a plateau of activity, productivity, where you're going to go and run through and you will complete your CESR program. So I think the CESR journey is very similar to this kind of a curve. Mentoring, very important. You'll be lucky if you find somebody who can sort of guide you. And I'm not sure what the true origin of this quote is, but I always find it very useful when it says, when the student is ready, the teacher will appear, or the teacher is available. Right. Now the tips for applicants. Some of these slides are actually copy and paste from the Royal College. So go through in detail from the college website in the FAQ section of the CESR applicants. So read all the guidance. Attention to detail is paramount. Umer has gone through that in detail. All areas of the curriculum need to be covered. There is no sort of ifs and buts about that. And the primary weightage is given to your evidence that you present to the college within the last 5 years. The college will consider evidence from before, but it's the past 5 years that are absolutely critical. So be very sure about that. WBAs stand for the workplace-based assessments. They're all available on the college curriculum website, and they must not be bunched. And they do need assessor comments. So whenever you get an assessment done, In the final box in there, please do ask your assessor to make a comment. Umair touched on a very important point. Become a Royal College member, get the access to the electronic portfolio. That's really important. That will save you a lot of paper, and this makes it much easier for your assessors, for your supervisors to fill up these forms for you. And you must triangulate your evidence, and we'll come to that in a bit as well. So some of the examples of WBA tools, you might not be familiar with that. I think in Pakistan, the College of Physicians and Surgeons, they do have certain DOPS and other sorts of evaluation tools there, but clinical ratings scales, DOPS, OSATs, these are different kinds of tools which are used within the UK. So the key point I would remember from this slide is do not bunch, please. This is a problem that is seen not particularly with the CESR candidates. It's also seen with the ARCP candidates, that a lot of these competencies are just done within the few weeks before your ARCP date comes in, or before you're sort of submitting your application. If you're meticulous, and if you have done like a prospective sort of a log of your records of your clinical logbooks and your surgical logbooks, you would end up staggering them. You would have a staggered approach with them, and you can fill them over a period of time. The reason all of this previous bit is important is because we work as voluntary CESR assessors. We are enthusiastic. We want to support our colleagues because myself, I went through the process, and I know a lot of people who went through the process. Your application shouldn't make me like this. And I'm thinking, what is happening here? And this is what I end up with. So this is really important. Nice, meticulously index portfolio, and an application has got much greater chance of success. The triangulation of evidence, this is again taken from the college. I've put it in a traffic light system as very weak evidence. If your referee says that you meet all competencies, that's not really a great bit of evidence. Similarly, if a consultant says that you do meet requirement, again, that is evidence, but that is a weak evidence. A much stronger and robust evidence would be considered as separate WBAs stating your competence, plus the assessor's comments, plus backed up by the logbook evidence. This is untriangulated, and the CESR assessor will look at the referee statement to corroborate that all of this is correct. So please do mind this, in fact. And if there's one key message from this talk, from my sort of a talk, is just remember this slide. Umair has talked again about the various other things that you have to do, and there is no good time to start, but start from day number 1, because you have to do all of these things. But if you are a middle grade SAS or a fellow in UK, and you are doing annual appraisals and revalidation in 5 years, pretty much you will be doing all of these automatically, and you should keep a clear record of that. This is again a second problem with the application that I've had over the last many years, is that you can't find the evidence. The evidence that is sent to the assessor by the college via the GMC consists of anywhere from 1,500 to 2,000 pages. And I think there are some other senior assessors who are attending the meeting as well, and they will certainly vouch for that. We can't look into anybody's brain and find out exactly what they were trying to say. The evidence has to be clearly signposted for the assessor. It's as Umair mentioned clearly in his talk, it's a tick box exercise at the end of the day. If the tick is there and it's clearly signposted, the application will pass. There is no reason to failure. Now, why are applications unsuccessful? Well, there are just 3 main reasons why they are sort of end up in the negative. Just simply because the curriculum is not covered, or it's not sufficiently current or maintained, by which I mean that it has to be within the last 5 years, and that's where the primary weightage is. There is a bit of a leeway you can get away with. For example, if you're in medical retina and you have a lot of experience in that, and you've done the cornea grafts about 6 years back, college will consider that. But it's rarely due to professional attributes. Just remember that majority of the middle grades that I have come across in my experience over the last 20 years in UK, they are really good ophthalmologists. It's just they need that extra level of guidance and support and mentorship to take them to the next level. So it's very unlikely that you would be a poorly performing professional and you would still be going ahead with the CESR route and sort of a passing. That won't happen. So some of the examples of limited evidence, I'll skip through them quickly because I'm mindful of the time as well. I think question and answer will be quite interesting for this talk. And these are all available on the college website in the FAQ sections. For example, in the plastics and adnexal, you have to do a botulinum injection, which is PS15. If it is not there, you will fail. Similarly, in corneal external disease, if you are out and out VR subspecialist person, you still have to demonstrate that you have assisted with 6 corneal grafts, and you have to read up on the latest guideline as well as the previous speakers have commented. Similar goes for glaucoma or retina, and these are all examples of people who have actually have had deficiencies in their portfolios from actual CESR applications, and they can be found out on the FAQ section of the college website. Please make logbooks, do this prospectively, do things electronically, and it'll be much easier at the end of the 4 or 5 years. Neuro-ophthalmology. And the key bits, one of the key things is that do not forget that general and emergency clinics are a wonderful source of signposting patients to a particular subspecialty. You might see somebody with a Horner syndrome that might eventually need a sort of a MRI scan or an MRA scan. And you almost can cover 2 or 3 sort of competencies just by following that case up. Similarly for pediatric ophthalmology, so it just sort of gives you an overview of the limitations that you might have within your application. So the recipe for success, I'll be moving towards the end. I think we'll just try to move quicker to the Q&A session. Only proceed when your training and experience you feel is pretty equal to that of a newly appointed consultant. For somebody who's working in the UK, if you've worked here in a unit for about 5 years, you know when you're ready. And attention to detail has to be meticulous. There's no way, there's no sort of other route around it. And this will, the first 2 things surely will logically come through with reading all the college guidance, the latest Royal College guidance, ensure every single competency is covered, and take your time with the application. I think the college, you get about 6 months or so. I'm not sure whether 6 months or 12 months once you start your application. Don't start your application too early because there's no point to do that. And if the application is excellent, with the exception of a single required competency, it will fail, and it has failed. And it can be quite sort of demoralizing and frustrating if you have that outcome. FRC Ophthalmology has pretty much explained why you need to do that. I've sort of had applicants that had to go through their applications, even working as locum consultants, having published 40 or 50 papers in renowned journals, and yet they had only submitted with 300 cataracts. That's not going to get you a CESR success. So please make sure that read the guidelines and make sure every single competency is covered. That's the message. So you can earn the money back, but remember the time is the money that you're spending that you'll never get back. This is a time that you're spending away from your family, and a lot of this work will be done out of hours, after the weekends, all of this filling stuff. So make sure that invest wisely. And to all those who are undertaking this journey already, I do wish a happy journey and a road to success, and I'm pretty sure you'll do very well. Please follow the British Pakistani Ophthalmic Society forum if you wish to, or you can contact me directly on my hospital email as well. And I thank the faculty for inviting me. Thank you.
Thank you very much, Sabza, for your brilliant talk. May I request all the panelists to turn on their videos? And let me first introduce our panelists, in addition to the brilliant talks that we had by Stephanie, Raja, and Omer. Can I introduce Mr. Kashif Ali? He is a consultant and lead for glaucoma and clinical lead at Countess of Chester Hospital. He's also a senior CESR assessor for the Royal College. Can I welcome Professor Wajid Ali Khan? He is the Chief of Medical Services at Al Shifa Eye Trust, one of the biggest eye hospitals in Pakistan. He's also Dean of Pakistan Institute of Ophthalmology. Can I welcome Mr. Manzur Saeed? He's a VR consultant at Queen Elizabeth Hospital NHS Trust, and he's also a senior Royal College CESR assessor. And can I also welcome Ms. Ukasha Ducht, who is a glaucoma fellow at St. Thomas's Hospital, senior glaucoma fellow at Guy's at St. Thomas's Hospital. Right. Can I start first with a question? And please, can I ask Omer first? You mentioned that you have to have FRC op to apply for CESR. Is that right? I think that may not be the absolute requirement. It will definitely help, but do you have to have an FRC op to apply for CESR?
The college has updated the page, and the guidelines are absolutely clear. And I don't remember there are very limited exemptions they've still given, which is the old FRCS exam by the Edinburgh, which was done, I think, before 2002 or something like that. That's the only exemption college has given. Now, the criteria is, as Mr. Raja said, that you have to triangulate every evidence. And most of the time, one of the triangulation is the knowledge aspect of that competency. And that is fulfilled by the exam. And so it is absolutely essential that we follow the knowledge criteria that's been highlighted on the college website. And it's categorically, they've said that it's FRCOP, except that FRCS Edinburgh, which was done, I'm not sure exact date, is 2002 or 5.
Before 2000.
Yeah.
Right. Can I ask any of the panelists if they want to comment on it? Because yes, Manza, because I think that may not be absolutely right for my Pakistani colleagues who may be thinking of applying.
Thanks, Akaf. First of all, it's excellent presentations, and I appreciate Umair's very positive introduction to the CESR process. Until at least a year ago, any evidence equivalent to FRC opt was acceptable. But if you had FRC opt, it would give you a very clear advantage. Firstly, it almost ensures that you've covered the college curriculum. So, for example, in one of the curriculums, if, for example, understanding of corneal graft HLA compatibility is required, we know that if candidate is done a FRC opt, he or she would have covered it without having to find specific evidence in the portfolio. I think it's highly advisable. If you can do FRC opt, please do it. It will be certainly, I think, escalate your chances of getting a CESR.
Does anyone else wants to comment on it? Yes, Ukasha.
Yeah, I would like to add here, there is another exception, is the specialty fellowship in ophthalmology by the examination of FRCS at Edinburgh from January 2001 till August 2012. It still exempts the FRC of the exam. The CESR application is the CESR application and guidance is approved by the Parliament, and it's been implemented by the GMC. So the GMC website, the updated document still doesn't say that the FRC opt is required. However, it's highly unlikely to get the CESR without the FRC opt exam.
Yeah, that's the point I was trying to make for some of my colleagues who may not be in the UK, that by legislation, the college cannot ask for FRC opt. I've sat on the education committee when this was discussed, and I basically commented against it, argued against it, because that would be against the law. That is why even if you go into the Royal College website, they cannot say that you have to have it. It will be very helpful to have it, but it's not possible. It's still possible to get CESR without FRC opt. If in a tracing institute like probably what Professor Wajid heads in Pakistan, if they have the same workplace assessments that we do in the UK, if they create the same kind of a system there, there's no reason why you can't have a very good portfolio within Pakistan, and you just have 1 or 2 years extra when you come over here, UK, to get a successful CESR application. I think that's where I was trying to make the point, because there are quite a few questions in the question answer section where Pakistani colleagues are asking whether they could do something in Pakistan in preparation for a CESR application. So it may be possible. There's also a question, I think it's more for Umair and people who have done it recently, and for the CESR assessors, that if you don't do on-call, because some of the SAS colleagues do not do on-call, can they still apply for a CESR application? Does anyone wants to talk about it? Stephanie, what do you think? Do you can still have a successful CESR application without on-call?
I think you technically can, but obviously there'd be lots of bonuses. I think as Mr. Raja said, you know, you're on call, you have lots of opportunities to see some of the cases that you need to get experience of. But I mean, I mean, someone who's filled in an application can tell me, Umair, do you definitely have to say that you've been on call to get it? I'm not sure you do. I think you just need to proof of the competencies.
No, definitely not. It's not
Yeah.
the requirement of the curriculum, but and it's still, I don't think so. You definitely need it, because the emergency, for example, emergency lateral canthotomy, that is still can be signed off as part of the LTS procedure, normal
Yeah.
lateral canthal sling. So you can get that signed off in a routine elective procedure. You don't necessarily need to do that.
The only thing I
Yes,
would,
it's much easier that you are doing on calls, that you come across more opportunities to glue the cornea and all these things, but you can get that signed off in wet lab as well. So there are opportunities without it.
I think the only thing I would say though is if your aim is to get a consultant job in the UK and you've not done on call, you might struggle with that bit of it because you know there'd be an expectation of what you'd have to do. So that would be my caveat.
Definitely. There's a question, the first from one of the colleagues from Pakistan is there an alternative like MSF, multi-source feedback, that we have in UK, which is a requirement now probably for a successful CESR application? Can they do something like that in Pakistan? So I think Professor Wajah, you may be the right person to answer this. Have you got any provision to having a multi-source feedback in Pakistan?
What exactly is this multi-source? Because we are not really familiar with that.
Right. So basically, it's just like over here, you have to nominate 15, 16 colleagues who know you, and then somebody sends them a questionnaire about you, a similar questionnaire, and then they reply that his mannerism with the patients is good, his clinical knowledge is good. Okay. Right. So even if there isn't multi-source feedback from, organized by the College of Physician Surgeons in Pakistan, but maybe an institute like yours can start that for colleagues who want to do a little bit of their, you can say, portfolio within Pakistan.
Right. Okay. Well, first of all, let me thank Dr. Ijaz, yourself, and Dr. Raja, Dr. Pasha for allowing me to join this wonderful session of webinar on CESR. It was really an eye-opener for me and a very, very informative session. I'd like to congratulate Dr. Stephanie West, Dr. Kidwai, and Dr. Raja for their wonderful talks, very nicely presented and very nicely done. I also am very happy to see Dr. Ukasha and Dr. Kashif on the panel, because they are our own resident and they have worked at Al-Shifa. The answer to your question is that, we have a sort of a system in Al-Shifa where all our residents are evaluated every quarterly. And there are certain parameters on which we evaluate them. Let's say, for example, if a resident comes for the first quarter to a cornea department, then after 4 months, he will be evaluated on certain parameters like his surgical skills, his clinical skills, his attitude to the patients, and so on and so forth. And this is done by the team of head of the departments of all the institutions, all the specialties. So they basically, in a way, it's not exactly what you're talking about, but in a way it is there. And I think that can help people who want to sort of apply for the CESR program. But I think I'm taking a lot of points back home today to incorporate into our training program, so that in future people should be having more sort of easy access to the CESR program applications.
Can I ask Kashif, do you think is it possible to at least fill part of the portfolio that you require for CESR while being abroad, meaning in Pakistan, India, or any other country?
Yes, definitely. I think, first of all, I would want to thank the speakers, Ms. West, Mr. Kidwai, and Mr. Raja for their excellent talks. Before I answer your question, can I just very quickly touch upon the qualification, the FRC requirement for CESR, please? Basically, it is not a definite requirement, but the onus is on the candidate to prove that their qualification or their knowledge is equivalent to FRC Opt, and that would be very difficult without actually taking the FRC Opt exam itself. In response to your question regarding getting some of the evidence from abroad, I think the main thing about is about presentation of that evidence. So you need to collect it, and you need to be able to present it in a manner that it would be acceptable to someone who is assessing your application. Logbooks is a very good example, or clinics or patients seen are very good examples. So if you are maintaining a very good logbook where you specify whether you have done a procedure, or you have done it under supervision, or you have assisted, or you've actually supervised a junior doing that procedure, if you document it properly in the required format, then that would certainly be acceptable as a CESR assessor. But that needs to be within the last 5 years. It needs to be recent and current.
Can I ask the same question? What do you think, Dr. Raja, Mr. Raja? Do you think we can help like CPSP or institute like Shafa to develop their assessments on the same pattern as the college CESR application, so that our colleagues, who are abroad can still feel part of the requirements while not being in the UK?
Absolutely, why not? I think the programs in Pakistan, I'm not sure whether it's a 4-year or a 5-year, and Professor Wajid can correct me on that.
It's a 4-year program now.
So I think obviously the 4-year program versus a 7 or 8-year program in UK are entirely different. It's a different way, but you can have certain beginnings in there, as Kashif has already mentioned in there. And just to touch on the point, and I think Ukasha mentioned that, Umer mentioned, Steph mentioned, and Kashif mentioned, my personal advice is, if you're not doing FRC, or if you're not undertaking FRC of the exam, probably don't apply, go for the CESR route, because it's not likely that you're going to get through. And that, I think that has to be one of the top line messages here. The reason is that as Kashif said, the onus or the burden, the amount of portfolio that you would need otherwise without the exam is just going to be too much. You might need a double PhD and sort of pretty much cover all the 7 areas of ophthalmology, which I think in one lifetime is going to be difficult for anyone really to achieve. So I think the easier way is get FRC of done and get done away with that. Certainly, I mean, all the material for the OST curriculum is available on the college website. The MSF sources are available. It's a pretty common thing, I suppose, done not only in UK, but in USA and many European countries as part of their curricula as well. And certainly, I would be happy to help in my capacity as part of BPOS or individually as well, to be a part of starting these different areas in sort of a Shifa, and if Professor Fawzi so wishes.
Right. Yeah, I agree with you, Mr. Raja, because without an FRC of the exam, it will be very difficult to have a successful application. In fact, I was in the meeting where the overwhelming view of some colleagues in the education committee of the college was to make it a mandatory requirement, till somebody reminded them, I reminded them that that is legally not right. So they didn't make a mandatory requirement, but that's the thinking is within the college. So maybe the recommendation would be, especially for colleagues who are not in the country, that instead of doing FRCS Edinburgh or FRCS Glasgow, you do them, but also consider doing FRC Opt if it would really help you through the CESR pathway. And believe me, CESR pathway is not that difficult if you are really start your training or start your portfolio at an early stage. So can I ask Stephanie, in your next application, if you have a candidate who is not in the UK but he provides you with a start of a portfolio of, say, a couple of years, exactly like what the college requires, with proper logbooks, proper workplace assessments. And he comes for you can say in your applies to your CESR training program. Would that evidence that he had gathered outside the country, but on the same pattern as what the college requires, would that application help him? That portfolio will help him getting a position in your esteemed training program.
Absolutely. I was just going to add a couple of things. One is, I think has been alluded, is all of the forms are available in paper format on the website, so you can do all your case-based discussions. And also, I actually did my 7th year of training, not in the UK, I did it in Toronto with my fellowship there. And I actually got the Toronto staff or consultants onto the portfolio to assess me so that I could have my last year of assessments done. So I don't know if that would be something that would be able to be explored probably much longer term. But no, in Southampton, what we are looking for is people with the ability to progress. So we look at more at your enthusiasm for achieving this. And we relatively recently, in the last, not the last time, but the time before, we took someone actually who was very junior as ST1 level equivalent. And in fact, we would expect them only to be submitting the evidence from their last 5 years and to actually spend 7 years with us. But we want people who say you've been doing ophthalmology, 5 years worth of ophthalmology, you've shown that you've made effort in trying to achieve things. So if you've done MSFs, if you've done, work-based assessments and things like that, you are the kind of person that we think will succeed. So definitely.
Right. Mr. Manzar Said, can I ask you, there's a question in the question answer section, and I'll just read it. Do we need each subspecialty experience letters, presentations, etc. signed and stamped, or with the new verifier system, this is not required anymore? You are on mute, Manzar.
I think as far as I know, you still need individual specialties as per college curriculum. Is that the question?
No, I think the question is that in the past, if I remember correctly, when you submitted your whatever your documents, each paper needs to be stamped and signed. But now I think they have made the system a bit more easier, that instead of getting each paper signed. Is that right, Manzar?
No, I'm sorry, I haven't come across any latest portfolios, and I've heard that it's also going online now, rather than having to submit papers individually.
Sapta, you want to comment on it? This new verifier system?
I think as Manzar Bhai alluded to, I've not had any chance in the last 6 months to do any assessments, but previously every single competency had to be validated and stamped.
Yeah.
But that would then be scanned. That would then be scanned by the applicant and would be put up as part of the portfolio. Now, as Umar mentioned, that there is electronic access available. Umar, do you want to make a comment to that, please?
Yes. So I think the question is about the subspecialty letters, and yes, it is required because it gives you as Mr. Raja said, you have to triangulate every evidence. Okay, so when I showed you the two important blocks, which is the number of clinics and the number of the procedures that you've completed, the subspecialty letter is a very good way of combining both of these together in a letter signed by the subspecialty consultant. Verification is altogether a different process, and that's been much simplified now by the online process, but it has nothing to do with the subspecialty letter. You still have to get the subspecialty letter signed off, which confirms that you have attended number of clinics and you've performed the number of procedures. It is also complemented by the logbook that you provide, which shows you that you have done so and so cases and so clinic. But this subspecialty letters are still required. And I just
can you just explain the verifier system as well? Because I think that how do you verify your 1,000, whatever
So
documentation?
now the simple is the system is now much simpler. Previously, when it was a paper application, every paper that you submit needs to be verified by a verifier, stamp and signature. Now that's not the case. First of all, they've identified the documents that does not require any verification. For example, your CV does not require any verification. Mainly the documents that require verification are your logbooks, your subspecialty letters, or any form of for the clinical work that you've done, plus the portfolio. Again, if you've done the portfolio through the college website, you don't need any verification for that either. So if you're doing the paper assessment, paper competencies of those WBAs, then you need that to be verified. And the verification process is so simple that at the end, you need to make a form and you need to only write the document that you've listed and the number of pages of that document. And that's it. That's a plain form, and that the template of that is available on website. You need to fill that up at the end. And before you submit the application, you need to send electronically all the data or give all the data to the verifier, and the verifier should be in agreement with you, and they will provide you some details of their GMC number, and they will look through the data officially. And when the application is in the process, the GMC will only select few pages of that verifier pro forma and send it back to the verifier. And then verifier will only look at those few pages. It might be just 5-10 pages, just to confirm the reliability of the verification process. That's it. So it's much simpler now.
Right.
Mr. Afsar, can I
Thank you,
just say 2 or 3 more things that's been discussed previously, if that's okay?
Yeah, sure, man.
So one of the questions, again, the FRC opt, the thing that I want to highlight, maybe, some people might get away without doing the FRC opt, but the risks involved is really high here, because we don't understand the fact that the process from submission of application to the approval of the application takes about a year. So, and you are quite tight in terms of your competencies that you filled up for 5 years. Let's say after 5 years, if they return back your application with incomplete knowledge portion because you haven't done the FRC opt, you will be in serious trouble, because you might need to cover the rest of the competencies that been lost in that 1 year. So now you have to reprogram the whole 5 years from that point. So again, I don't think so it's wise to go for application without FRC opt. And second question was about the MSF. So lots of us don't have access to the college e-portfolio still, so we don't have MSF, official MSF. It's good to get MSF as you get the Royal College portfolio, but you can still do the 360 degree. That's part of the appraisals in every trust. But in Pakistan, if you still want to do it, you can still do it in a very good way. That there are lots of websites with like Survey Monkeys and all these things, which you have to pay for a bit. And then you can officially do a 360 degree survey with your colleagues, and that is still acceptable. Plus you can get the paper formats of the competencies, you can sign that off in Pakistan, and that is still acceptable. The only issue is that the logbook of the Royal College doesn't work outside UK. So you cannot enter the procedures that you've done in Pakistan on the logbook, but you can still show a parallel logbook method for that.
Thank you, Mir. Can I ask, Ukash, there's a question here. Can we collect subspecialty case log from the patient seen in general clinic? In other words, in general clinic, if you see a specialty patient, can you use that in your portfolio?
That's a very good question, very pertinent question, but the answer is not pretty straightforward. I would like to answer, and I have been asked this question before as well. According to the guidance and the guidelines online, there are 2 guidelines that I would strongly recommend the candidate to go through. One is the CESR Ophthalmology guidance. It's on the GMC website regarding CESR. And the other one is the frequently asked questions, as said by Mr. Raja. And that is the RCOF website. It's very clearly written over there that you have to provide the evidence of the clinics you have attended, and that is the minimum 20 clinics per subspecialty. However, the neuro-ophthalmology part is a bit difficult. It's usually is not available for every candidate because it's usually present in a bigger setup. So the only thing that is asked is to provide the equivalent amount of the number of patients that you see in the other subspecialty clinics to provide in neuro-ophthalmology. 120 number that usually people provide for neuro-ophthalmology. However, I would like to ask these questions from the assessors because do you want to have 120 clinics, 120 patients logbook for a specialty? Because this is the question that everybody is asking. And they're being put off because of it, because there's a lot of the data you have to collect.
I think Mr. Said has got his hand up.
Yeah,
Yes, sir.
it's a common question. But if you, for example, have a Horner syndrome patient from a general clinic and it presented nicely as it should be, yes, it will be acceptable as a good evidence. But it will, if you're required to do 20 neuro clinics, that would still be required. This is so. In short, yes, you can select cases from your general clinics if they're done properly. Say if you've done a neuro session somewhere and you've not had a chance to complete your portfolio within those 20 clinics, you can use your cases done in general clinics.
What about the cornea subspecialty and the glaucoma subspecialty? If somebody has done 20 clinics, they still need to provide 120 cases, is probably the question they would like to ask and would like to know.
120 cases of
cornea and 120 cases of glaucoma, even though they have done 20 clinics as asked by the Royal College.
Yes, if they've done 20 clinics from a corneal clinic and they've done cases from a variety of other clinics, yes, it will be acceptable. The management of a corneal graft will still be the same, whether it's done by a generalist or a corneal specialist. But of course, some highly specialized procedures may not be available in general clinics, such as DMEC or DSEC,
So if they haven't done the 20 clinics, if they provide the evidence in a form of 120 patients, will it be acceptable?
I suppose so. The quality of cases will reflect that how good the work is. For example, how should I put it? DCRs, if you need to assist 6 DCRs, it doesn't really matter whether you assisted a generalist doing DCR or a lacrimal surgeon doing DCRs. Would other assessors agree with that?
Yeah, Mr. Raja, do you want to comment on it? That if the requirement is, for example, 5 neuro clinics or 2 neuro clinics, and you don't do those 2 neuro clinics, but you have seen enough neuro patients, would that be acceptable?
I think Kashif raised his hand before me, so let him answer that.
Okay, sorry, Kashif, I missed your hand.
No, that's all right. Basically, because neuro-ophthalmology is different, it's not available in all district general hospitals. So I think while assessing applications, most of the times neuro-ophthalmology is slightly lenient as far as my experience is concerned as a CESR assessor, because we understand that not all applicants would have had the opportunity to go to a tertiary unit to attend neuro-ophthalmology clinics. But as to what Tukasha was asking earlier regarding cornea clinics, for example, if you attended 20 clinics, you can give an example of what you see in a clinic. So it doesn't have to be all the 20 clinics. You can give 1 or 2 clinics as examples, that this is the scope of work or this is the experience that you get in those clinics. That's my understanding.
Thank you, Kashif. Just to take that point further, Akasha, about that, if you're seeing about 150 odd cornea patients, you're likely to be working with a cornea consultant. So I think the point here is really the triangulation of evidence. And if you are able to get a validated WBA or an electronic WBA signed off by a cornea consultant, that should be accepted by the college. If you have got any doubts, and you're not and sometimes we are a bit behind the latest updates from the college as well. Email equivalence@rca.ac.uk, and they generally tend to reply within 3 to 4 weeks. It's much better opinion you might get from there if you've got any issues about any competency. So that's equivalence@rca.ac.uk. I mean, as Kashif mentioned, not every unit, not every DGH is going to have all the subspecialties. For example, ocular oncology. There are only 4 centers in UK: London, Sheffield, Liverpool, and Glasgow. Not everybody lives close to that. I live about 400 miles away from there. But you can demonstrate these competencies locally as well. And you might have to go to a regional or a neighboring unit about, say, 20 miles away, where you can demonstrate these. But again, it's the way how you present the data. If you have any doubts, and this is for all the CESR applicants, any doubts, email college about it.
Thank you, Sabda. Before Stephanie leaves us, can I ask her a question regarding her excellent CESR training program in Southampton? Did all the consultants, all the educational or clinical supervisors for these CESR trainees, do they get time within the job plans to do this? Is this role agreed by the management?
Yeah, they do. So I think the recommendation is 0.25 per trainee PA, and we allocated that from the beginning. And in fact, the CESR lead also gets allocated. And we sort of did it just in our unit to start with, you know, under our clinical lead, essentially allocating it. But yes, we absolutely do. So
I have a quick question for Stephanie as well before, please.
Yes, Kashif. Yeah.
Yeah, I mean, first of all, many congratulations in establishing this fantastic setup for CESR. It's really enviable and commendable. It was exciting to hear that, despite losing 4 full-time doctors with 3 sessions each, you were able to increase your productivity, and financially you made a profit, and efficiency was increased. But you mentioned that your trainees did not actually have any setbacks, and their number of cataracts increased over the 6-month period from 42 to 51. How do you explain that the trainees were able to get more numbers?
Oh, that's because what was happening before is we were having a lot of sickness, and essentially what was going on is whenever someone was sick, they would be pulled out of their theatres, etc., in order to cover. So they would be forced to go down to casualty to run eye casualty instead. And also there was sickness amongst them. I mean, morale was pretty much rock bottom as such.
That's really interesting. That's very interesting.
So they were being pulled from pillar to post to do things and losing out on theatre. And also there was a whole mixture, like I became very protective that you can only have 1 trainee in a theatre session. We will have a trainee and a fellow, and which the fellow is meant to be at a much senior level, but you will have 1-to-1 training, whereas before people would just be all shoved into theatres all over the place, and so equally you had less exposure. So yeah, that was undoubtedly the main reason, is their theatre time essentially became a lot more protected.
Yeah, I mean, because theatre capacity is the biggest hurdle in a lot of hospitals.
Yeah,
because you can't really give 2 theatre sessions to all the SAS doctors or all the people who want to actually operate.
No.
It's very interesting to hear how you incorporated Optegra.
Yeah. So that was, I went there as one of the first consultants there. And what happened is, because it wasn't approved by the deanery, it was an opportunity for me to take the CESR trainees there first. So we had, I think, 2 consultants went to Optegra. So we used those as their operating lists for cataract surgery to begin with. Then ironically, they were getting better exposure often than the deanery trainees, because they were the more inverted commas, straightforward cases.
Microscope at Optegra then.
Yeah.
What was that, sorry?
You had a teaching microscope at Optegra?
Yeah, they did. Well, part of a lot of these things like the ISTCs, contractually, they are meant to provide teaching. And in fact, Care UK in Southampton, one of our consultants went and worked there so that we could take a trainee there as well. So we found other ways of getting cataracts exposure to our trainees. And so we took our CESR trainees there first, and then they were actually getting better exposure, because what was happening is that the more complex cases by nature were actually in Southampton General, and the more straightforward cases were going out. But now, obviously, all places, we were just rotating trainees in between them. And in fact, we've expanded further now into Lymington, and we are getting more, hopefully, touch wood, more theatre space. So I think, if we end up with more theatre capacity, we would expand our training program. But that is the absolute linchpin to running it, is being able to give them the surgical training that they need.
Fantastic. Thanks so much for sharing your experience.
No, it's a pleasure.
Can I again thank you, Stephanie, for finding time to join the BPOS
No, that's fine.
webinar, and thank you for sharing your experience, and especially about your cataract experience. I think this is the way forward, because in our region with Spa Medica, increasing their hospitals which are doing
Oh, yeah.
cataracts from
They're coming
17
to us.
yeah, they have increased their hospitals from 17 in 12 months during the COVID to now 28.
Yeah.
And next summer they will have 35.
Yeah. They're coming to
So our
Southampton.
training for cataracts will be probably
Yeah.
not in NHS hospitals.
But they legally have to supply training. So
Yep.
yeah. That's got to be looked at. I'm
And
afraid I've got to go. I've got
thank you once again. Well, hopefully we'll see you again in another webinar.
Definitely. Thank you very
Right.
much, everyone. Lovely
Thank
to
you.
meet you all.
Thank you, Steph. Bye.
Right. I know we are running late, but can I ask the rest of the panelists if they have time? Can we have quite a few questions? Can we continue for a few more minutes? Yeah.
Yep.
Right. So there's a question here that it's probably for all the assessors first, and then I'll take the second part to Professor Wajid, is that if a trainee or a colleague in the UK, if he is having problems getting the surgical experience, the question is especially about squint, but let's make it more generalized. Any surgical experience where they are not getting the enough numbers to complete their CESR application, can they get their experience from abroad and get it signed up over there and use it over here? Can I ask Mr. Raja first, and then Mr. Saeed, and then Mr. Ali to comment on it?
Thanks, Ahmed Bhai. As yet, I've not had any application that I've assessed over the last 5 years that has come via this route to be sort of. But I can certainly say that if there's a proper logbook evidence of that is validated, I can't see any reason why that should not be accepted. And that would be my take as an assessor on that. So I would certainly accept that. It's then up to the college and GMC to whether accept or reject my recommendation.
Can I take the view of Mr. Said?
Remember a candidate or two who had done this. One very brilliant candidate had gone to India. She had done enucleations or some sort of orbital or corneal graft procedures. I think corneal graft, they were at a big national corneal graft center. And that was very nicely presented and accepted as a good evidence.
Right. Kashif Okasha, do you want to comment on it?
Yes, I would be happy to accept it as long as it is in the same format as the Royal College of Ophthalmologists recommends. So if it's clear that the procedure was done independently or whether the procedure was done under supervision. And ideally, there would be 1 or 2 OSATs from that. And that would kind of triangulate the evidence to say that, yes, it was done in time. So I have actually accepted foreign-based evidence to complete surgical numbers in one of my recent applications.
Sure. Okasha, Omer, do you want to comment on this?
I have come across few of my colleagues and friends who have had their experience accepted from abroad. However, it was not the big chunk, and I think it depends, how they have presented their evidence, and I think why not?
Right. So, Omer, have you known any colleague going abroad to do some experience?
No, but in the other subspecialties, for example, radiology, it has been widely accepted all this time. But I would like to say 2 issues with this. Number one is, sorry. The number one is they should remember that a part of the GMC verification process is if you change the center, you need a different verifier performer for that. So make sure that there is someone willing to verify that. And GMC has certain requirements for that as well. For example, in order to verify, the email address that they accept has to be with domain email. For example, if it's a Yahoo or Gmail email address, the GMC doesn't accept that email as a verifier's email. So it needs to be a domain center. For example, if it's like the Al Khan, they've got their own aku.org domain. So if you're doing in an organization which has their own domain and the verifier there who's going to verify these evidences, make sure that they've got their own domain. Otherwise, it will be a very difficult issue to verify at the end and you will get stuck. And secondly, all these things come into your mind when you're struggling with these odd areas. But honestly, I think much easier way of doing this is to look for local areas. Lots of people do that on honorary contracts, and lots of trusts offer you honorary contracts. So you do an honorary clinic a day, and they let you do the theater as well one day with the consultant, and you can fulfill these requirements within UK rather than looking for opportunities back home. So I think there are ways to avoid this if needed.
Yeah, thank you, Matt. I think moving forward, there might be a little bit problem with cataract surgery, at least in our region. Even the trainees from the deanery are struggling to get cataracts because we have a lot of private providers around. So, we'll see what the future holds. But Professor Wajid, would your institute be willing to accept some candidates from the UK who send you an application to say that, we are here and we would like to come to your institute for experience of, I don't know, having a few squints or having a few phaco surgery experience?
Yeah, this is a very interesting question, and I was actually expecting that as well. Basically, as a policy, in Al Shifa, we were not really entertaining people who wanted to actually start the surgery training. But if somebody who's experienced enough and they want to sort of, complete their numbers, as you said, I think that is something we can always look into, and that is very, very much doable. But to let's say to expect somebody to come and just to start the training program or just to start the training here at Al Shifa, that may not be easy thing to do. But I'm very open to this idea of people who would like to come over to Al Shifa with having some background surgical experience, reasonable experience, and then sort of completing their numbers with us. I think that will be something which we can always look into. We have lots of cataracts, as you know, in Pakistan, and so we have a huge number of surgeries in Al Shifa, which they can actually come into the system. We are now doing almost 700 corneal transplants a year, so that's again a large number, which we can always facilitate people who have some experience, but they just want to sort of add on the numbers. So that would be something which we can always talk about.
Right. Well, thank you for that. Just before I forget, you mentioned a couple of panelists as working at Shifa. You forgot me. I have worked in Shifa for 1 day. That was my first job after becoming MBBS. I got your whatever your scheme was at that time, I don't even remember, 94. So, but I joined for 1 day.
All right, that's even better. That's even better.
Yeah, I got the job, but I came to UK. Right. So moving on.
Sorry, can I just make a point about Professor Wajid's comment on getting trainees from, say, UK and trying to fill up the numbers? I think it's a key competency for CESR has to be the audit trail and the patient safety. So the patient has to come first. It's absolutely vital that the people from Pakistan shouldn't be entertaining somebody who's just starting, say, a cataract operation. So somebody who's up and running, who's an independent phacosurgeon, just needs that extra bit of a few numbers to go. I think that is the way forward. I mean, corneal grafts is a different sort of a beast, so you just need to probably assist at 6, but something like a phaco operations or something that needs more independent hands-on, I think you need a reasonably skilled operator to go there. And I would be a bit reluctant to actually send a junior fellow to Professor Wajid to actually learn these sort of things personally.
Yeah, absolutely. Good point, Safdar. In fact, like you mentioned, maybe if, for example, some units don't have corneal grafts happening at the moment, and if a colleague probably just needs to assist, so maybe Professor Wajid can help in that because it's not doing surgery, just assisting. Similarly, VR, you just have to assist. So if you don't have a VR unit locally and for any reason you are in Pakistan, and maybe Professor Wajid can help in that because just being in the theater and assisting it. So moving on, there's a question about that if you're a locum consultant, can you ask your consultant colleagues to help you with your workplace assessments? Mr. Said, do you want to answer that?
Surely would be more than happy to do so. In my VR domain, I have done that for individuals in the past. One thing I was going to say is that when you're assessing these applications, you are potentially looking at a candidate who could be your colleague tomorrow. So it doesn't matter what your current role is, staff grade or locum consultant, but as long as you have all those attributes, Someone mentioned about the on-calls. It's not so important to be doing on-calls. It's what you're able to do if you are on call tomorrow. Such as the evidence of open globe trauma repair. It's not easily found in many candidates who have worked in non-consultant grade for many years, might be excellent surgeons for elective surgery, may not have had a chance to do a corneal perforation. So please make an effort to fill those gaps in your portfolio.
Right. There's a question here. If somebody wants to comment about academic route to specialty registration. I don't know who wants to answer it. It's difficult, so somebody who wants to answer it.
I think that's an interesting one. There is a route for medical ophthalmology program, which is a 5-year program, but generally people have done MRCP UK, and then they've gone on to the medical ophthalmology side. And obviously they're not likely to be surgeons. So I think in ophthalmology, as a middle grade, it's gold dust to find somebody who doesn't want to operate, which means that you don't have to allocate a theater. If there are competent ophthalmologists and don't want to operate, come to Great Yarmouth. I will be very happy to take them. But I think progressing to CESR route is not going to be likely, in my opinion. But I'll be happy to learn from Mansabai and Kashif and see what they say.
Yeah. I think there's also an academic route for, like, if you are, for example, if you are, biotech chief scientist who has, done something like that, and he wants to come and teach on the register, then I think there's an academic route, which is very, very few people will be able to apply through that. But it is something there in the legislation. Mr. Saeed or Kashif, do you want to comment on it?
I'm not aware of academic
I have not had any experience in assessing any applications through the academic route, so my knowledge is limited to what is available on the website.
Sure. I think it's like Professor Domato went to LA, or I know at California, or somebody from, a professor from America, wants to come and work here, who is a well-known authority, then he may not have to prove that he has done a temporal artery biopsy.
I think they won't be going for the CESR route though, so that's one thing as well.
No, they have to technically go through CESR route, right? They have to technically get their application through GMC. So that's I think for whoever's asked the question, I think it's a very difficult route for academic route to consider, because for that you need to be a well-rounded authority in a certain subspecialty. And I'm not sure if you are, why would you want to come to UK? But anyway, if you want to, then I think there's a way out for it. So there are quite a few questions. I think we have answered it. It's about that, which basically says if you've done FRCS Edinburgh, if you've done ICO exam, does it still allow you to apply to CESR? So does anyone want to comment it? Yes, you're allowed to apply, but whether the application will be successful or not, Kashif, do you want to comment on it?
Yeah, so ICO would not help you prove that your knowledge is equivalent to FRC Opt. And similarly, I think Ukasha earlier mentioned the duration of FRCS specialty exam and the old style FRCS Edinburgh you yourself mentioned earlier. I think if somebody did their FRCS such a long time back, then over the last 14, 15 years, they're already well established. So for the newer candidates, there are very few candidates who would actually have been, who would have obtained their qualifications such a long time ago. So I don't think there is, ICO has any exemption for FRC Opt.
Right. So can I ask Ukasha, there's a question. How many competencies in a day will be considered as punched? I work as a locum consultant and utilize my free admin session. That means 2 clinics in a day for CESR. I discuss a case and do 1 DOPS and 1 CBD per clinic. That means sometimes I get 3-4 things signed in a day. Will this be okay?
It's very difficult to say because the OST program, a trainee usually provide about 12 CBD per year. and they usually do it for 7 years. So they bunch up, they usually have got a CBT number of about 84. While the CESR applicant has to provide their evidence for 5 years. So obviously they cannot provide 84 CBTs. Bunching up an evidence it's difficult to say. I think in what my opinion is that if you are giving an evidence or you're doing a workplace assessment, for example, a CBT to sign off the histopathology part of it, but you have done the tab in that patient, then you can still provide the CBT of the same patient and can still ask somebody to sign you off for the tab. However, I think it's bunching up too many evidence, in like 1 or 2 weeks time. I think it's not ideal. And if you're providing, for example, 7 CBTs per week, then it means that you haven't given enough of time for the discussion. And there is no set time. Otherwise, I haven't actually have seen online anywhere that there's a set time. However, they always say that 7 CBTs in a week or 2 is something that cannot be done.
Right. I think we have already ran over quite a bit. And thank you very much. Can I especially say thank you to Professor Wajid for finding time to join us.
It's my pleasure.
And we will be inviting you on more webinars, especially related to the subspecialty cornea. And thank you for your offer for our colleagues in the UK, that if they ever are in Pakistan, if they need some experience, that you may be able to help. And thank you once again for coming. And thank you for Kashif, Mr. Raja, Ms. Ukasha Dokht, Mr. Manzur Saeed, and Umair Kidwai to finding time to attend today. And hopefully we will continue this series. And thank you for all the attendees who still, there's quite a few still here. So thank you for attending the BPOS webinar. Please, there's a Facebook page for BPOS where all the webinar recordings are present, the previous webinars, and this webinar recording will also be posted there. And also follow us on our Twitter, which is at BPOS786, where we will give all the information of all the webinars that we'll be hosting. Thank you, and have a nice evening.
Thank you.
Everyone, thank you for the participation.
Thank you. Bye-bye.